Good afternoon. I'm Robert Dempsey, and for the Department of Neurological Surgery, we're going to give a brief update on the COVID-19 crisis, where we are worldwide, where we are locally, and how it's affecting us and the people around us. I want to start by pointing out that we're in the middle of a crisis. There's good news and there's bad news both, and I want to emphasize the good because we want to be optimistic. I want to start with just a story of what's been happening, because I said weeks ago that crises bring out the best and the worst in people, and I think sometimes we should celebrate when we see goodness in people. And that's the story of the Choctaw Nation. Now, the Choctaw Nation is a nation that of Native Americans. As you know, we've been active very much in our department with our local tribes. But they live in the southwestern United States and were victims of the Trail of Tears relocation. But 170 years ago, after they had been relocated and settled down in the Oklahoma area, and then Arizona and New Mexico, they read of the Irish potato famine and the deaths in Ireland. They sent $170, 170 years ago, to Ireland to help starving families. They now are in the midst of the COVID crisis, and as you know, that particular area of the United States, the reservations are suffering from a surge or outbreak in it. In response, there's been a funding effort in Ireland to try to provide food, water, and medical supplies to the Choctaw Nation, so far to the tune of $3 million. So I think goodness is repaid, even if it takes a long time. And I think that these things bring out the best in people. It is a very serious crisis. I said earlier that weeks ago, I said that some of the earlier smaller epidemics, Hong Kong flu, etc., were of 1 million people. We're now at 4.2 million people worldwide that we know of. And of course, all counts based on tests are vastly undernumbered. But when we look at this, we can see that there are almost 300,000 deaths worldwide. The United States has about a third of the cases, 1,300,000, but 82,000 deaths. Wisconsin is definitely not a hotspot or surge spot. There are 10,000 cases in Wisconsin, 400 deaths. And Dane County is, even for Wisconsin, been very protected. And I believe this is completely true to the fact that people in Dane County have stayed home, have stayed protected, had followed the rules, because there's only 477 cases in Dane County. There are lots to be learned from this, because it means, one, we've done a very good job of protecting each other. Two, we're susceptible because we have no innate immunity in this region should things get out of hand. That's important to know. The desire to reopen is very real in people and the reopen the economy. I would argue strongly that we have learned how to do that safely here in the hospital, here in the county, with physical distancing, masks, clean gloves, etc., which will allow us to safely open some businesses, some industries, but not all. And our lives are going to be changed for some time to come. So this is a time to be sensible, but to understand that there are several factors. We've learned even recently, as we begin to scientifically study this virus, that one, there is not much native immunity in our region at all. Less than 1% are testing positive for the antibodies. We should be happy that we isolated properly, but we should be forewarned that that is basically within the air of the antibody tests. So we do not have an innate immunity. We also know that this particular virus is mutating slowly. And that is both good and bad, as was the thought that I started this talk with. It's good because it means if a vaccine is developed, it will be very slow to outwit the vaccine, unlike some other, like flu virus, which keeps changing so rapidly that the vaccines aren't keeping up as often. This is likely to be affected by an effective vaccine, but it'll take some time. But what it does mean is that the other way that pandemics end is often because not everybody was infected, but the Hong Kong virus mutated, did not reappear as virulent the next year. This mutates very slowly. There's other issues that we need to know about, which are coming out of the scientists and the medical doctors. When we look at the frequency of COVID virus, it may be much higher than we think because we've been testing only the nasal epithelium, the nasal mucosa, and it's probably very likely, as I mentioned a few weeks ago, the receptors for this virus are seen in many other cells, brain, kidney, blood vessels, heart. And this may be why this disease that we're seeing in children, which is Kawasaki-like, which attacks the vessels, is present, and they may be tested negative nasally, but I believe we'll find their antibodies are positive when we start looking at that. So the possibility of other diseases or increase in heart attacks, deaths, may be the best way to study this pandemic. And when we look at that, we see that the numbers in areas like New York are probably twice as high as we've been able to test. That's important because it impacts on should we open schools, should we gather in large groups in the fall for football games. And I think that that's something that I will leave to common sense, but we would say that we must continue to isolate, we must continue to use masks as we begin to open up our lives, our economy, which I think will happen inevitably. The only question is, will we do it safely? If you look at the situation here at UW, we have been able to demonstrate that we can keep patients safe and staff safe. The rates of COVID within our staff are consistent with what they would have picked up in their lives outside the hospital. We've not demonstrated anybody being infected in the hospital, which is very, very good. So we've begun to open up the ORs. We're at about 73% of capacity. Now that's important for many reasons. It means that we're able to take care of people who would otherwise be very deathly ill if we had delayed their surgery much longer. And we hope to open it up even more sequentially over the next weeks. The clinics are probably at a considerably lower level in-person visits, but the use of telemedicine is, especially the video medicine, is rapidly increasing to the extent to which I believe we will hit 70% of the usual number of clinic patients being seen electronically and in person, with in person being no more than a third of that number. This means that it's time to go see your doctor if you have medical problems. And the message is it can be done safely, it can be done with video, it can be done in person with appropriate barrier precautions. But we need to get the word out that people should not be neglecting their health, their blood pressure, their chest pain, their weakness, which we've seen too much of people and children coming in with their tumors too large because initial symptoms were ignored out of fear. So we're trying to say the new normal is very different. We're going to look differently, but we're going to live a safer life. The safer includes getting your medical care. Laboratory testing is now available for antibodies. I'm not seeing much more than what I talked about 2 weeks ago. The epidemiologists are learning that there's very little in our local region. That's important, but I think the antibodies will be hugely important for the unexplained vasculopathies of the toes of the children or unexplained heart attacks or the increased stroke rates, and that will be important. So the scientists are helping us in the laboratories, just as they did with the initial testing. The clinics are opening up, but they're different. The ORs are opening up, but very carefully. And the next thing I think was we looked at patients in ORs, patients in clinics as students, and we do have a strategy now to teach the first and second year medical students mostly online, but begin starting with the fourth year medical students to include them in the experience in the hospital. And I think that's very important. They need to be exposed and learn as to what you do in a crisis and how you react. We have enough personal protective equipment for that to happen. And if we do not get a surge of cases here, we will be able to do that. The third-year students should follow in July. So we hope that in June and July, we'll be able to see that increase. The next thing is the labs. As we know that the dean sent out his message this week that indeed we can open the labs if the research can be considered important or essential for overall health care. It can be done safely with physical isolation in the lab, safe egress and entrance and egress from the hospital, and the coordination with the supplies or animal care that be needed for this, because that's important that we continue to go on. To do that, a request needs to come to my office, which will be seen by the dean's office for their approval, and it should make sense that it is important medical research that can be done, that can be done within the limits as we open up other facets of this. I think the future is really important to get a handle on. You can tell that we live in a restless society that wants to reopen, that wants to restart the economy. I fully understand that, but it has to be done safely. I think that we're going to learn from what we've learned in the hospital that there are ways to do that, ways to open our lives up, to interact. As the weather is getting warmer, we're seeing more and more people that lawn chairs physically spaced on their driveway. They invite their neighbors to talk and they interact more. People walking interact as they pass homes because people are getting out in the front of their yards. That's important. But with a slow mutation rate and a high infectivity, the news is we really do want the idea of a vaccine. There are COVID viruses that we've never been able to get an appropriate vaccine. They've mutated too quickly. This one we might be able to, but I don't expect that before the winter. Therefore, we need to begin to start lives carefully. Physical distancing, and we begin to look at what's been done. We can use techniques, modern science. They actually look at cell phones. The cell phones in Dane County in the last month have really been interacting with minimal number of people compared to even regions of Wisconsin around us. And that's reason why our infectivity here has an R naught below 1. Now, a virus cannot sustain an epidemic with an R naught below 1, meaning that it infects one person and infects less than one person. But even as high as an R 1.5, which we see in other parts of Wisconsin, could cause things to step up. Right now, I'm not aware of any major hotspots outside of the reservation that are not leveling off. We look at the death rates and the case rates in the United States, they're still quite high, but they are leveling. That means that what's going on is working. We need to continue that as a society, as a medical school, as a department, and as individuals well into the new year to really conquer this. But I do think that we're coming into a new stage of this where we're very cautiously taking steps to get back to work, to get back to some semblance of normal. There's still a lot to be done. A lot of it is to look after each other. By what we've been doing, we've kept each other safe. We have a lot of lonely elders. We have a lot of lonely elders that aren't taking their blood pressure medication. So the hospital is beginning to send out the message, it's okay to see your doctor. It's okay, because we've been seeing way too many hemorrhages and hemorrhagic strokes. And the message comes out that we're in this for the long haul, but the long haul includes semblances of normality, which includes contact, maybe with separation with people, medical care, and continued science into this. I think we've really, even the last weeks, as we look at the genomics of the virus and the serology of the virus, we've learned more and more, which will make it safer. This is why we've always stressed testing, because the way to conquer this really is to find the cases, find their contacts, isolate them for 2 weeks so it doesn't spread. They are not falls, and this thing begins to die out. That's what I have for us today, and I hope that it has optimism. It's long and slow, but that's good. We're good at this. And doing it together, we will succeed. I'm happy to answer any questions anybody might have, either on chat or by opening their mics. And thanks for everything you've been doing. And let's hear it for the Irish and the Choctaw. Questions from anyone? And the main thing we're seeing on chat is the constant idea that people that are going to be in close contact or people that are going to be at risk of aerosolizing should be tested. That, of course, makes sense. Okay. I want to thank everybody for what they're doing. Keep up the good work. Appreciate it. And more we're getting back to our normal lives in a new way, but I think we're better for what we've learned from this. Thanks for all you do.